Welfare Committee for February 18th to order. First up on the agenda, we have a hearing on Senate Bill 174. And just a little bit of housekeeping for everybody. Just due to the volume of testimony that we have, we're going to do it a little bit different than normal. Since we have to be out of here in 50 minutes, that's our time limit. We are going to divide up the time there between proponents, opponents, and neutral. Each conferee will have 2 minutes to testify. But if you are a proponent, you have a total of 20 minutes. So if a conferee goes over their 2 minutes, you are eating into somebody else's time. So be mindful of the next conferee that you're not taking up their time. And with that, also, there was a couple of handouts given to you. Feel free to use those however you need to use them. So first up on Senate Bill 174, we're going to have an overview from our reviser, Jenna.
Yes, good morning, Mr. Chair. Thank you, members of the committee. Senate Bill 174 would concerns advanced practice registered nurses, which I will refer to as APRNs. And this bill, or its mirror, had a hearing in the House yesterday. And so instead of my usual bill brief where I walk through everything, I'll focus mostly on the issues and questions that came up during that House hearing in order to expedite the process along. In the first section, which is in Chapter 40, which relates to insurance, it expands the definition of healthcare provider to include an advanced practice registered nurse. And this does two things. One, it would subject those providers to the requirement of maintaining professional liability insurance, and also that an APRN would have to pay into the Healthcare Stabilization Fund. The next sort of highlight would be that this bill changes the requirement that currently exists in law that an APRN would have to, in order to prescribe drugs and practice the full scope of what they're authorized to practice in, would have to have a written protocol as authorized by a responsible physician. And this bill would eliminate that requirement. And on page 10, this is some of the requirements in order to be licensed and practice as an APRN. It would require 4,000 hours of clinical practice hours or clinical instruction hours in order to have full practice authority. And there's nothing in this bill that changes what an APRN is required to or is allowed to practice. The main change would be the elimination of the requirement for that practice agreement with a physician. And I know that was kind of brief, but the proponents will have a lot more to say that can cover it more in depth, but I'll be happy to answer any questions.
Thank you for that explanation. Committee members, do we have any questions on the bill draft? Okay, seeing none, we are going to move right along to proponents. And committee members, we are going to hold questions until the end. And just a friendly reminder to our conferees, we do have a copy of your testimony. There's definitely no need to read it. And we are going to keep to 2 minutes and 20 minutes of time. So at 8:53, we're going to cut off proponent testimony and move on to our neutral. First up, we have Amy Seipel. She's the president of KAPN, and she is attending virtually. Amy, welcome to the committee.
Thank you so much. I appreciate Jenna's introduction. What Senate Bill 174 does, it removes the requirement of collaborative practice agreements and written protocol language. This outdated regulation has created barriers in access to care. In today's landscape, it's very difficult frequently to find a physician who's even willing to sign a CPA. And when you do, often exorbitant fees are attached to it, making the economics of it just not feasible. Now, I have collaborated with numerous physicians through the years, and I certainly don't need a government regulation to do this. I turn your attention now, please look at the map that is attached to my testimony, where you can see the healthcare outcomes of states that have removed these barriers. So when we remove barriers to access of care, we obviously will see improvement in healthcare outcomes, and we want that for the residents of our state. I ask you, please don't let this be about turf battles. Look at the evidence. There are over 200 studies that show that APRNs provide safe and effective care. We want the best healthcare outcomes for Kansas. This bill, as was also stated by Jenna, requires APRNs to have a structured transition to practice, carry malpractice insurance, but it also requires all APRNs to maintain national certification. So what this bill does not do, as Jenna talked about, this does not change our scope of practice. APRNs will continue to render care in accordance with our education and certification. It does not change the fundamental elements of collaboration. We will continue to collaborate. In fact, it's a requirement of our bill and of APRN professional ethics. Finally, I just want to say that because we were not able to see the bill before it was thrown in, we have a balloon amendment that would conform the bill to our original draft intent. We've worked with Representative John Barker, and the reviser Scott Abbott has the draft amendments attached. Thank you.
Amy, thank you very much. Next up, we have Sonia Slaba. She's an APRN and with the Kansas Advanced Practice Nurse Association. She too is testifying virtually. Sonia, welcome to the committee.
Thank you. I'm an APRN from Wichita. I hold 3 board certifications as an APRN. I am here because I lost my youngest brother to suicide in 2015. After his death, mental health became my passion, becoming involved in every activity promoting mental health awareness and suicide prevention. I wanted to focus on mental health and provide those services to Wichita. I obtained my psychiatric mental health nurse practitioner degree after I discovered mental health services greatly lacking in Kansas. Through my advocacy work with the Sedgwick County Suicide Prevention Coalition, I found that suicide is the 8th leading cause of death in Kansas and the 2nd leading cause of death for 10 to 44-year-olds. My brother was 22 years old, and that's why these statistics mean so much to me, as his death is counted in these statistics. We are losing our youth to suicide, partly due to lack of access to care. I am part owner of a clinic that provides mental health services to Sedgwick County. Our collaborating physician is 73 years old, and the harsh reality is that if he were to stop practicing for any reason today, whether that be retirement or death, our clinic would have to close, leaving all our patients without mental health services and the medication they need. They would have to find these services in an already too congested mental health system because it would take months, if not years, to secure another collaborating physician for our clinic. It took us almost a year to secure the current one. I volunteered with the ICT Street Team, an organization serving the homeless in Wichita. This has opened my eyes to mental health and how it afflicts our very own community. Our street team collaborating physician places limits on what we can treat. She does not allow us to treat pregnant women, so we cannot offer expectant mothers any treatment. I have volunteered with Via Christi Medical Mission at Home for 2 years in a row. I had 2 different collaborating physicians each year, whom I've never met. So in total, I have had 4 collaborating physicians in the last 5 years, and I have only met 2 of them. I urge you to pass Senate Bill 174. We don't need a permission slip for the physicians. We get that through our education and certification. Thank you.
Thank you very much. Next up, we have Michelle Knowles. She's an APRN, and she is going to testify virtually. Michelle, welcome to the committee.
Thank you. We know access to healthcare improves quality of life, contains costs, and reduces the use of emergency rooms for non-emergency conditions. In 2016, the VA chose to remove CPAs to improve access to care for veterans. Our scope of practice did not change. Collaboration and referrals with physicians did not change. Patient outcomes remained excellent. What did change for patients was access to care was improved, wait times were decreased, and veterans got test results and prescriptions much faster. We already have VA, Indian Health, and military clinics and hospitals across Kansas with APRNs providing care under their own licenses, clearly demonstrating safe, quality care with trustworthy regulation through the Board of Nursing. None of the states with full practice authority have gone back to reverse or add restrictions. This tells you quite a bit. Many are in the Midwest with the same rural access and shortage issues that we have. They have increased access to care statewide without changing quality of care at no additional cost to the states. States increase the number of APRNs after full practice authority. We have lots of examples. Nebraska increased NPs by 40%. 20 underserved counties saw increases. Arizona saw a 73% increase in rural areas. Nevada, 33%. North Dakota nearly doubled their workforce. Minnesota increased 30% in shortage areas. Many states like Wyoming changed to full practice authority over 35 years ago before we had any time. I have more studies in my written testimony. Senate Bill 174 has been proven to work. APRNs are more likely to work in underserved areas and care for Medicaid, Medicare, and uninsured patients. Studies confirm there are equal or better outcomes when CPAs are removed. This is not a new concept. All of our Kansas citizens need to benefit from the provisions of Senate Bill 174. Thank you.
Thank you, Michelle. Next up, we have Matthew Allen from Garden City. He is also testifying virtually. Matthew, welcome to the committee.
Thank you, Mr. Chair, members of the committee. For the last 13 years, I've served as the city manager for Garden City. My professional experience has helped shape my perspective on this issue, but this testimony is my own. In 2012, the city of Garden City started an employer-based single-payer wellness and nursing services clinic in response to our 370 insureds, almost 900 lives, facing, along with the employer, double-digit percentage increases in health insurance premium and an erosion of our health insurance plan. It's been overwhelmingly successful. In fact, 9 years later, it's still in operation, and the total increase for both the insurance plan and the cost to operate the clinic only represent a 3% total increase from what we were spending for health insurance in 2012. That's a total increase, not an average annual increase. That's far below 0.5%. Satisfaction among our workforce is way above 90%. Participation is nearly 100%. The cumulative budgetary savings to the city of Garden City is on par and actually exceeds almost any of the major industrial or commercial projects that Garden City's done in the last decade, and there's been several of those. This case study provides evidence of the transformative impact you can expect from unshackling nurse practitioners to do what they are trained and capable of doing in Kansas, especially since there is a shortage of care in most of the state. Garden City was one of those deserts. Over 2/3 of our workforce were undoctored, not because they chose to be, because it was not available. Family practitioners were not taking new patients. I would encourage you to help Kansas minimize and potentially eliminate its healthcare deserts by removing barriers that limit supply and increase profits for those working at the bottom of their credential and allow nurse practitioners to operate at the top of theirs. Thank you for this testimony.
Matthew, thank you very much. Next up, committee, we have Kathy Gordon. She's an APRN and she is testifying virtually. Kathy, welcome to the committee.
Thank you so much. Thank you, Chairman, and all the committee for allowing us to have this opportunity to testify on Senate Bill 174. We are so happy. My name is Kathy Gordon. I am a dual licensed APRN. I'm licensed as a family nurse practitioner and also nurse midwife. Many years ago, I worked in the emergency department, one of our busiest ERs in the state, and I saw firsthand how many Kansans use the ED for primary care services. Most of them were the working poor. It didn't work. They couldn't leave their jobs to go see a provider, or they didn't have a medical home, and they used the ER as their go-between. I looked at that need in our own county of Johnson County and did a little homework and found out Johnson County per capita has more underserved and uninsured people in our state than any other county. And I thought, wow, can I make a difference here? I took a step in faith and started a clinic myself as a nurse practitioner with another nurse practitioner, and we served those people. We became an advocate for those in the ER to refer to us so that they could afford a healthcare clinic that was in their area and that had optional hours. That clinic soon grew out of its capacity, and we expanded into another county, Wyandotte County, and serving around 11,000 people a year. These clinics are still open after 20 years of service, meeting the healthcare needs of thousands. You may have heard of it. It's called Mercy and Truth Medical Missions. While this might seem glorious, it was very difficult for us to find a physician who would sign a collaborative practice agreement for nurse practitioners. First of all, 20 years ago, it was kind of unheard of, a nurse practitioner-based clinic, really? And so to find that person actually took an act of God for someone to trust us, to walk in faith, and to grow a relationship with us. Unfortunately, that wasn't always the case, that it could be an act of God, basically. We had problems. I had lost sleep over when our physician became ill, or when one chose retirement. And I even had one that died. And so if I can give you that example of 10 o'clock at night and I'm calling our backup plan saying, hey, I've got a problem, something happened and we no longer have Dr. XYZ, I need your help. The concerns of vicarious liability, binding contracts with their own employers for the idea of being competitive, and financial gain were all the things that made it difficult for us to find that perfect physician to sign with us in a medically saturated area like Johnson County. It was a constant restrictive burden to seek out a physician to sign an agreement for a nurse practitioner to render services in Kansas. I urge you to vote for Senate Bill 174 for Kansans. I gave you my written testimony. It's much more detailed, and I'll be available for questions.
Kathy, I'm
Thank
sorry,
you.
you're over your 2 minutes, so thank you.
Thank you.
Next up, we have Nicole Lavanas. She's Associate Director of Legal Affairs for NCSBN. She is testifying virtually. Nicole, welcome to the committee.
Thank you, Mr. Chairman. Since May, APRNs in Kansas have been caring for COVID-19 patients without collaborative practice agreements. That's thanks to swift action by this legislature and 11 other states that removed these barriers during the pandemic. The swift and smart actions increased access to care during an unprecedented healthcare emergency. And while these agreements have been lifted, the Kansas Board of Nursing, or KSBN, has continued to regulate APRNs. In fact, they've been regulating APRNs since the 1970s. Nationally, APRNs are regulated by boards of nursing solely in 47 states, including all of the full practice authority states, 23 plus DC. It's been mentioned by some that regulation of APRNs in Kansas should be moved under the Kansas Board of Healing Arts, the physician-controlled regulatory body in the state. In addition to the unknowns of this policy, the Federal Trade Commission specifically weighed in on this issue in a letter to House Leader Hawkins in 2020. The letter's attached to my testimony, but I'll summarize 2 key points. First, they warned that moving APRN regulation under the Board of Healing Arts would be anti-competitive. They warned that this unprecedented move would discourage new entrants into the profession, deter competition, and suppress innovation and services. Kansas needs more healthcare providers and greater access to those services, not less. KSBN are experts in APRN regulation. They license, discipline, approve education programs, and enforce the Nurse Practice Act for APRNs. The board regulates their current scope of practice, which, as Jenna mentioned, would not change once Senate Bill 174 becomes law. 2 APRNs serve on the board, and they have an advanced practice committee that's an advisory committee to the board for further expertise. Their expertise is why APRN regulation under the Board of Nursing is appropriate in Kansas and the 46 other states where it is law. Thank you for your time.
Thank you, Nicole. Next up, committee, we have Dr. Jamie Harrington, and they are testifying virtually. Dr. Harrington, welcome to the committee.
Thank you. I am the president of the Kansas American College of Nurse Midwives, and I'm here today to urge your removal of this requirement, which is literally just a piece of paper, a permission slip to practice. If you're one of the lucky ones who can find or pay a physician to sign this, then you can still practice, but many APRNs are unable to do this. Removing this, as stated before, does not mean that APRNs will be practicing alone. Both APRNs and physicians always maintain collaboration. This is already the standard of care and will not change, and this doesn't require a written agreement. I currently own my own clinic, but if I lost my permission slip tomorrow, my business that I poured my heart and soul into would be forced to close, leaving my rural community without OB care. Already in the short time I've been an APRN, I've had to change practices 5 times when I lost my permission slip because a physician left our practice. Because of this requirement, at one location, I had 400 pregnant women that I was seeing that were forced to transfer to other providers, some without insurance, some unable to see anyone because of that, and some late in their pregnancy being forced to see someone that they didn't know or they did not trust when they could have continued to see me. This is unacceptable. We have worked with Kansas physician groups for over 5 years, and we were the only ones that compromised by adding the 4,000 hours of transition to practice language, which this is one of the highest in the United States. Because we were told our education wasn't good enough, even though most APRNs also have years of bedside nursing experience prior to becoming an APRN, experience that you don't get in medical school or when you go directly into PA school. If you look at the research, study after study document excellent APRN outcomes, increased patient satisfaction, and less litigation. Please support this bill and get rid of this outdated requirement 24 states already have, and ultimately let consumers choose who they want to see for their health care. Thank you.
Thank you, Dr. Harrington. Next up, we have Judy Davis. And just a quick reminder to the conferees, we are under 3 minutes to go for your time, and we still have 3 conferees. So Judy, welcome to the committee.
Thank you for the opportunity to testify in favor of Senate Bill 174. I'm also a retired master's prepared nurse, but I'm here in advocacy for AARP of Kansas. AARP does support this bill because of our growing age group. It's a major consumer of healthcare. We need access to quality, cost-efficient healthcare, especially in the area of primary care. But there's a shortage of primary care physicians in Kansas. While there are 360,000 APRNs in the nation, 270,000 of which are nurse practitioners, and 87% of those practice in primary care. Some argue that physician oversight protects the public from poor and/or dangerous care. But no, the National Academy of Medicine found no studies that indicate that APRNs are less able than physicians to deliver safe, effective, and efficient care. Some argue that APRNs need to be regulated by the Board of Healing Arts. But no, both professions practice healthcare, that's true, but from entirely different frameworks of care. Nursing is a profession that has always been separate from medicine. APRNs, it's unnecessary to be oversight by physicians. Public perception, a 2018 AARP survey of Kansas voters aged 45 and older indicates that 87% of voters support allowing APRNs to serve as primary care provider of record in Kansas. In summary, elder Kansans need more access to primary care. APRNs can alleviate the shortage of primary care providers. Nursing is a profession separate from medicine. APRN care is readily accepted by Kansas citizens. Please support and pass Senate Bill 174. Thank you.
Judy, thank you for your testimony. We still have 1 minute, so John, I don't see Eric. Eric or John want to take the remainder of the time? Okay. John Luth, welcome to the committee. He is with Americans for Prosperity.
Thank you, Chair. Thank you, committee, for allowing me to be here today. I'll try to move very quickly through this and certainly not say everything here. Just a few things I'd like to point out is that Kansas faces some of the worst provider shortages of any state in the nation. According to the U.S. Department of Health and Human Services, roughly 800,000 Kansans live in areas that face a severe shortage of physicians. This, along with a number of other reasons that I'm sure we'll continue to hear today, is yet another example of where it becomes harder and harder for APRNs to find a physician to sign on to these practices, an activity that can take months, if not years. More failed bureaucracy and failed government programs simply is not a way to solve this issue. One thing we know is that this bill is a tangible, changing result for individuals here in this state who are seeking access to health care. This body, the state, took action last year to remove this, and for this past year, we have seen the great tangible results of that. So with that, in the end, this is about getting more meaningful access to Kansans all across our state, and I ask that you support this bill.
John, thank you for your testimony. Committee members, Eric Stafford was scheduled to speak. We ran out of time with the Kansas Chamber of Commerce. He does have written testimony turned in, so I direct your attention to that. We also have several other written only testimony for proponents. We do have that turned in as well. So please make sure you look at that. At this time, we are going to open up for questions for proponents. Committee members, because of the time restraints, if we do not get to all of your questions, conferees, I would ask that you would give us the opportunity to ask any questions via email, and that you would respond appropriately and timely so that we could get those questions answered by our committee members. I just do not like to cut off any questions that committee members might have, but because of the time restraints, we probably won't get to every one of them verbally. So with that, committee members, Senator Thompson.
Thank you, Mr. Chair. Just one quick question. Is the barrier to having these collaborative practice agreements the fact that it creates a liability for the doctor who signs those agreements? In other words, he's supposed to be supervising an APRN. I'm just curious if any of the proponents could answer that.
This is Michelle, and I would take that question if you would like me to.
Michelle, please.
Okay.
Go ahead.
There are a couple of issues that happen. Number one, many more physicians are working for hospital associations and things like that. So they don't have the ability to choose whether they're going to sign a contract if maybe that clinic is freestanding and yet the physician works for a hospital. They may not be allowed to sign those contracts. Liability is also an issue. There's a perception that their liability will go up, even though the malpractice rates for nurse practitioners are around 2% and have stayed that way and are that way in the full practice states also. And we're losing physicians across the state to retirement, and we are not getting the replacements of physicians out in especially the rural areas. I hope that answers your question. If not, I can send you more in an email.
Well, that's good. Thank you. Thank you, Mr. Chair.
Thank you. Senator Stephan.
Thank you, Chairman. As we went through the proponents, the recurring theme that I saw is that it was independent practitioner after independent practitioner after independent practitioner. In my medical world, I see doctors moving towards becoming employees of hospital and clinics. I see nurse practitioners moving to being employees of hospitals and clinics. So can you elaborate some on whether this is really a real problem, or is this a problem for those nurse practitioners who want to be independent? Thank you.
Senator, this is Nicole Ivanos. I'm happy to take the question.
Nicole, yes. Thank you.
Yeah, thank you. And thank you, Senator, for your question. So this is a problem, not only because of the collaborative agreement and the difficulties you heard about obtaining and maintaining that collaborative agreement, but also because there's an access to care crisis in Kansas, not only in rural areas, but in urban areas as well. And we know from the 23 states that have removed these restrictions that the evidence shows that access to care increases, access to psychiatric care, primary care, women's health care. The evidence goes on, and I'm happy to follow up with you on that. So the problem is that, Kansas can really benefit, like those other states have, from removing these unnecessary agreements. And not only for independent APRNs that are opening their own clinics, but also for those that are working within clinics or clinics that wish to open in areas but can't afford the costly fees or can't sign these collaborative agreements. Thank you.
Thank you. Senator O'Shea.
Thank you, Mr. Chair. Question for anybody. Is the cost so if I'm getting the same service from an APRN versus a doctor, is the cost to the patient the same? Thank you.
Senator, I'd like to answer that question if that's okay.
Yes, go ahead.
Okay, that was a great question. I think that if I can use CanCare as our best example, currently reimbursement rates are different for nurse practitioner services versus physician services for the same fee schedule. And what that means is a typical office visit's coded as like a 99214. That's a typical visit, and the nurse practitioners are currently reimbursed at 75% of the physician's fee schedule on the CanCare schedule. So there is a significant difference. And one would ask the patient, were you billed at a different rate? And I don't know that you'll find that answer to be true if they're working under a physician. So CMS, so the Center of Medicare Services, actually does have a fee schedule that says physicians are reimbursed at a certain rate and nurse practitioners are reimbursed at a different rate. And that's a standard of care. So I hope that answers the question, and I'm happy to give you more information if that will help.
Kathy, thank you. And committee members and those listening in live, that was Kathy Gordon, APRN. Danola, we had a handout, and Christine White. Okay, thank you. Committee members, we are out of time for questions. Again, conferees and committee members, if you will direct your questions via email to Danola, she'll forward them to the conferees. And conferees, if you can get those answers back, that would be very much appreciated. Committee members, we are now going to move to neutral testimony. We do have one testifying in person. That is Doug Smith with the Kansas Academy of Physician Assistants. Doug, welcome to the committee.
Morning, Chairman.
2 minutes, sir.
2 minutes. I'll be quick. I'm here on behalf of the Kansas Academy of Physician Assistants. We are neutral on the bill, but we have concerns about future impacts to the profession for physician assistants should this become law. We are, PAs are medically trained providers regulated by the Board of Healing Arts who work as a part of the physician-directed healthcare team. Collaboration with physicians is the foundation of the PA training. We're not seeking a change in that, but we are concerned that there may be lost job opportunities for PAs in the future. PAs and APRNs have similar scopes of practice. They're trained differently. They are regulated differently. We have similar concerns, though. Physician loss is a concern for PAs because we work under collaborative agreement. PAs pay into the Healthcare Stabilization Fund and already carry malpractice insurance. So any changes that you make to for the APRNs are going to have an impact on physician assistants on the other end. And we want to just bring that to your attention, that we think that the providers who work similarly should be treated similarly in their regulatory oversight. As has been indicated, traditionally PAs worked for a physician under a solo practice or in a clinic, and that's changed now where both physicians and PAs generally work for a healthcare system. They're looking at cost controls and efficiencies. In some of those cases, they're going to look at the oversight or the regulatory burden that might be placed on employing a provider. And if the burdens are different for PAs and APRNs, the administrative requirements, they're going to go to that provider with the least requirements, and that's where we're afraid that we lose business opportunities in the future. I'd be happy to stand for questions at the appropriate time, but we just wanted to bring that to your attention today.
Doug, you are the only testimony verbally for neutral, so if you'd stand up there. Committee, we do have Tucker Polling with a written only neutral. Doug, one question I have, the difference between a PA and an APRN, just to clarify for committee, do you guys have to have a collaborative practicing agreement?
We do, yes.
Thank you.
Attached to our testimony is also some background on the PA profession and training and education that you might find helpful in your deliberations as well.
Thank you. Senator O'Shea.
Thank you, Mr. Chair. That was similar to my question, and so it sounds like this bill would not be eliminating the collaborative agreement for physician's assistants. Would that be a request?
At this time, the bill does not address physician assistants in any way. There would be some flexibility needed, I think, for our profession going forward should this become law. We are working with the Medical Society, and we will work with our regulatory agency, the Board of Healing Arts, to come up with language. But we're regulated like physicians, and so it's a little bit different practicing under the delegated supervision of physician medicine and surgery. The regulations are going to be a little bit different for us and how we address those going forward.
Senator Petty.
Thank you, Mr. Chairman. And thanks, Doug, for being here. Just glancing through the PA's guidelines for, they don't have to have a nurse background.
PAs generally have to have some medical experience before they go into PA school. Generally, it requires a bachelor's degree and then some years of experience in the medical field. And then it's a 27-month training program here in Kansas.
But they don't have, I mean, I know someone right now that went to PA program that, had experience of other types, but not medical experience. It has a 4-year degree. PAs don't have to, they don't have to have that as part of going into the program. Is that correct?
Nursing experience or medical?
Either one.
They have to have some form, whether that's a medical assistant or a technician. Generally, that's what they look for when they accept PAs into the programs, to have some experience, not necessarily, true medical experience as a nurse or anything like that.
4-year degree does not have to be anyway in nursing or.
No, it generally, it's in the sciences, similar to what a pre-med student may have. I mean, that's what we find our typical applicants have, is a pre-med background in the undergraduate, but they don't have that other medical experience.
Senator Stephan.
When I was in medical school, we had PAs in classes with us. Is that still the case?
No, in at least in Kansas, it's a standalone program for physician assistants at Wichita State, and it is all physician assistants only in that training program. So it's not commingled.
Seeing no further questions, Doug, thank you for your testimony. Again, if for some reason a committee person does have a question for you, we'll email it to you.
Be available.
Okay. Committee, we will now turn our attention to opponent testimony. First up, we have Rochelle Colombo, Executive Director for the Kansas Medical Society. Rochelle, welcome to the committee.
Thank you. Good morning, Mr. Chairman and members of the committee. I am Rochelle Colombo. I'm the Executive Director of the Kansas Medical Society. The Medical Society represents physicians across the state from every community and in all subspecialties. We appreciate the opportunity to appear before you today in opposition to Senate Bill 174. There's been a lot that's been talked about today. This is a complex bill. It deals with clinical care, and there's been a lot of terms put out that we haven't had a chance to talk about before in this committee. Independent authority, full practice authority, collaborative practice agreements. These terms have been talked about, and they all mean something, and they mean different things. There are a variety of different ways that nursing practice is regulated across the states. It was said by the proponents that there are 23 states where they have full practice authority, or and it was implied that what is before you today is what there is occurring in 23 states. That is false. It is widely different across the states. Some states have less supervision requirements, some have less scope allowances, but they do not allow what is talked about or contemplated here in this bill before you. This is often talked about as the independent practice of nursing, and I sincerely wish that's what we were talking about today. We oppose this bill because it does not allow for the independent practice of nursing. We are not opposed to the independent practice of nursing, but Senate Bill 174 allows for the independent practice of medicine by non-physicians. And they say repeatedly, this is not an expansion of scope. They do not want to practice medicine, that they know their limitations, and they'll be guided by education and training. But that is not defined within the bill, the education and training. It does allow for expanded transition to practice of 4,000 hours. But otherwise, there are no limitations at all that would distinguish the practice of nursing from the practice of medicine. If you look to the Healing Arts Act, which is KSA 65-2869, it goes through what the privileges are that are associated with the practice of medicine, which are currently limited to medical doctors and doctors of osteopathy. They include diagnosing, prescribing, initiation of and management of treatment, as well as the supervision of other healthcare providers. Those exact words are included in the scope of practice in Senate Bill 174. There is no limitation. Again, all other healthcare providers in Kansas, all of them that are defined, have a limitation that specifically says they cannot practice the healing arts, that statute. They cannot practice medicine and surgery. That is not contained in this bill. So there's nothing that would prevent a nurse with independent practice from performing surgery. There is nothing that would prevent them from prescribing on any level of the schedule. This bill makes a nurse a doctor. We don't believe that these professions are the same. The training and education are not the same. I won't have time to talk about all of the details, but I would point you to my testimony as well as testimony from AMA President James Madera. He talks at length about the difference in training and education, as well as these bills that have been pursued in several other states. I would point you to this wheel which I provided, which takes you through some of the professions and the training and education that is required. I would also point you to the neutral testimony of the Board of Healing Arts, where they talk about just that, the regulatory structure, the words in statute that help regulatory agencies actually enforce what the privileges are allowed. So I won't be able to get to all of those things. I do want to answer questions. Kansas Medical Society strongly opposes Senate Bill 174. And we do not believe it is in the best interests of patients, nor is it necessary to provide rural care or access. I also have a document that I included with my testimony that shows Wyoming, where they passed something similar to this, and it gives you a geomap that shows nurses are no more likely to move to rural areas when you pass this, relaxation of supervision requirements than they are when those don't exist. So I don't want to take more time from the other conferees, but I'm happy to stand for questions, and thank you for the opportunity.
Thank you, Rochelle. I would just ask one thing. I do not see the testimony that you referred to from James Madura. So if that is something you want us to review, could you make sure and get that to Donola so that she can distribute it to the committee?
Yes.
Thank you.
We'll do it. Okay.
Next up, we have Dr. Jennifer Mckinney. She is here with the Kansas Academy of Family Physicians. Dr. Mckinney, welcome to the committee.
Thank you so much, Chairman Hildebrand. I am a family physician in my hometown of Fredonia, Kansas, where I've been for the last 11 years. I am representing today the Kansas Academy of Family Physicians as well as the Kansas Medical Society, as we are aligned in our thoughts in opposing this bill. I think one thing that we have really learned and grown in medicine in our state and in our country, one theme that we've learned through data and research and just learning about patients is that team-based care prevents disease, saves lives, and keeps people well. No other time in history has this been more evident than during this pandemic, when we rely so much on respiratory therapists, our lab technicians, our housekeeping, and physicians and nurses alike, the entire team, to be able to save lives and keep people healthy. I feel that there's no reason that one single person should be responsible for a patient's care alone. Sometimes this is referred to as a turf battle, but this isn't turf. These are our patients, our family members, our neighbors, our friends. It's not about turf, it's not about statistics, it's not about income, it's just about keeping people safe. I trained for 11 years after high school. I did around 20,000 hours of clinical care so that I could do the things that I do for my patients in my rural community. To be fair, there's nothing special about doctors. We're not any better, we're not any smarter. We just did the training. We did all the things that it takes to practice medicine. And the great thing is that opportunity is available to everyone if they want to practice medicine. I personally employ an APRN, and she is one of the most important parts of our care in our clinic and in our hospital. I've never asked her to pay me for a collaborative agreement. I pay her malpractice, her salary, and benefits. Our collaboration is more than a piece of paper, but I really think that it takes both the APRN and the doctor to make that meaningful. She's one of my closest friends. She is one of the people that I rely on the most, along with the rest of the healthcare team, to take care of our patients. I don't have the same training as a lot of people on the healthcare team. I don't know how to do what they all do. So that's why it's in this team approach that our patients are ensured that they're receiving the highest quality of care. I'm a rural doctor, and rural care is complex. Sometimes I'm the only doctor in a 15-mile radius, and that gets really scary really quickly. Like when somebody walks in with a stroke, or there's a 5-car pileup on the highway, or somebody is suicidal in my clinic. It would be nice to be able to say, well, I only take care of this or that. But that's not reality. We can't just stay in our lanes and think that that's how things work. Rural care is very complex, and that's why included in my 20,000 hours of clinical training, I had nearly 1,000 hours just in neurology and psychiatry and trauma and critical care, and that's more than a lot of APRNs get for their entire training. So it's troubling to me that this bill is partly being sold to serve in a way to serve patients in rural communities. It's true that in Kansas, we need more of every healthcare professional. We need physicians, nurses, radiology techs, CEOs, paramedics. We need everybody. But right now, there is no barrier for these people coming to rural communities. Nothing stops them right now. So we know we have a shortage of these things. We have a shortage of nurses. We don't have a shortage of APRNs in Kansas. We're actually one of the top 3 states per capita of APRNs, but we do have a distribution problem. We have more APRNs in urban areas than rural areas now. So there's nothing in this bill that makes them move to a rural area. No reason why we would believe that that would make them move to communities like my own.
Dr. McKinney, I apologize. I don't know if we lost our time or not, but I do believe we are well over 2 minutes. So if
Gotcha.
if we
No
could just move
problem at all.
on to
Thank you so much. I just ask that we oppose this bill and help build stronger teams and stronger communities. Thank you.
thank you very much for your testimony. Next up committee, we have Vicki Whitaker. She is testifying virtually, I believe. Vicki, are you with us?
Yes, I am. I had offered to Rochelle Colombo to allow her to take my time, if that's okay with you. She's even more experienced with all of this than I am.
Okay, Vicki, thank you. And I think Rochelle, you. Okay. Vicki, thank you for that. Next up committee, we have Dr. Christy Clark. She's the president of the Kansas chapter for American Academy of Pediatrics. Dr. Clark, welcome to the committee.
Thank you, Chairman Hildebrand. My name is Dr. Christy Clark. I'm a board-certified pediatrician with 20 years experience, and I have served for 10 years in rural West Kansas. I'm here on behalf of the Kansas American Academy of Pediatrics. I serve as their president in opposition of Senate Bill 174. I collaborate, precept, and utilize as my own PCP nurse practitioners. Never done any of this for a fee. We believe that patients are best served by a physician-led team. I can provide further evidence from the AAP and the AMA, but all evidence I have reviewed show that laws in other states that have allowed for independent practice have not increased access in healthcare shortage areas, such as areas where I live in rural America. Also, they have found it's increased healthcare cost by, number one, increasing liability insurance for the nurse practitioner, which could be prohibitive for working in rural America. But also it can increase costs by cutting out that primary care physician team leader. You can have increase in unnecessary prescriptions, increase in diagnostic tests, and increase in referrals. Although these nurse practitioners who are an independent practice in urban Kansas are bringing to you valid concerns and bad experiences that they have had collaborating with physicians, that is not a reason to change policy for all Kansans. We want to do what is best for patients in Kansas rather than what is best for a profession. In rural Kansas, there's no avenue for independent practice. We work at a critical access hospital with a rural health center where we have to have a physician and a nurse practitioner working together. That's what CMS dictates. This 4,000 hours is very irregular. My 10,000 hours in residency in peds was not governed by the state of Kansas. It was governed by the ACGME, and I fall under the American Board of Pediatrics. This is very nebulous scope, very dangerous. If you do 4,000 hours in geriatrics, can you then see a pediatric patient independently? I urge you to look at this. It is in fact the practice of medicine that falls under the statute 652869. And as such, you're putting the practice of medicine under the Board of Nursing.
Dr. Clark, thank you
So-
very much for your, I'm sorry, but we do have to get moving on to the next
Thank
last
you very much for your
proponent
time.
or opponent. So conferee. So hey, thank you for your testimony, Dr. Clark. Next up, we have Dr. Christine White from Overland Park. Dr. White, welcome to the committee.
Thank you very much for letting me be here. How much time do we have left of our 20 minutes?
2 minutes.
Okay. So like I said, I'm Christine White. I'm a pediatrician in Overland Park, and I speak in opposition to SB 174. The views I express today are my own. In the last 18 years, I have employed and worked daily with 7 nurse practitioners. I feel 2 of those could safely practice independently because they have had between 15 to 30 years of experience. I have taught 7 nurse practitioner students, and not one could safely practice alone without another 4 to 5 years of experience after graduation. The reason is evident when looking at the training differences. The 2 pieces of paper that you guys have, the first one is the figure showing the differences in education between physicians and nurse practitioners. Physicians have 11 years of education. Nurse practitioners have between 6 to 8 years of education. Figure 2 shows the difference in clinical hours, which is time spent with patients. Physicians get 6,000 hours in med school and another 10,000 hours in residency. Nurse practitioners get only 500 to 1,500 hours, and they do not have a residency. The difference of 14,000 hours is crucial. I believe the only way nurse practitioners should practice independently is to show that they have had 10,000 hours of direct patient contact in one area of medicine post-graduation, or to complete a 4-year residency in the specific area of medicine that they plan to pursue. I also believe nurse practitioners should be overseen by the Kansas Board of Healing Arts. 2 years ago, when this bill was being heard in the House Health Committee, the president of the Kansas Board of Nursing stated she believed nurse practitioners should be regulated by the Board of Healing Arts, as the Board of Nursing did not have the knowledge or skills to oversee the practice of medicine. I worry about patient safety, as there is a difference in training, and that difference matters. The saying, true wisdom is knowing what you don't know, applies here. You have to have seen thousands of patients to know what is normal, so that when 1 in 1,000 comes in that's not normal, you know it. You get that second sense from thousands of hours of patient contact and work and study. There is no substitute for that. Thank you.
Dr. White, thank you very much for your testimony. Committee members, we do have a couple of minutes for questions. Marisa, I do have a question or a request for you. There was a lot of mention about the other states and how their APRNs are able to operate in those states. Is there a way that we could get a comparison of what Kansas currently does with the rest of the 50 states and get that to the committee members so we have something to look at and compare with?
Yes, Mr. Chair, we can definitely find and compile some information for the committee.
Okay. All right, thank you. Committee members, do we have any questions for any of the opponents? Senator Petty.
Thank you, Mr. Chairman. Dr. Jennifer McKinney, thanks for being here today. You mentioned in your testimony that you have an APRN that works in your office right now, that you don't have a collaborative fee that's involved with that. But I'm just wondering, with this legislation, would that change that?
With my relationship with my APRN, I believe that our relationship will continue to be strong. She has expressed no desire ever to practice independently. Our collaboration is beyond the paper, but I would never charge a fee for anything anyways. I guess, is that what you're asking?
So the legislation wouldn't have any impact on your relationship with your APRN or your working agreement as it is now?
I believe that it really comes down to relationships, and it's the responsibility of both of us, the APRN and the doctor, to be able to have a good collaboration and team effort.
And you are a primary care doctor?
I am, yes.
So in your training as a primary care doctor, you had rotations in all different areas, correct?
Yes.
So I've heard in some of the comments about the fact that, well, if an APRN had training in geriatrics, they would know how to work with other patients, but they also have trainings in not just one area as well.
True, yes. Although it's much smaller scale. And so when we do training in kind of the things I mentioned, whether it's cardiology, nephrology, whatever, I mean, we spend months just in those specialties each, but that also doesn't make me a cardiologist, you know? So it helps me do the things I need to do for my patients in my rural community, but I would never claim to be any of those.
Right. But they're not actually claiming to be cardiologists or either in this request of this legislation.
Sure. Yeah. Thank you.
Committee members, we're going to take 2 quick questions, and then we are going to be out of time. We're going to have one from Dr. Stefan, or Senator Stefan, and then Senator Baumgardner. Conferees, if you would, any questions that are directed from Donola, get those back. Thank you.
Thank you, Chairman. Just quick follow-up there. We did have a nurse practitioner claim to be a specialist in psychiatry today. And to the quality of the clinical they get, I followed a young lady through her nurse practitioner, and she did her pediatric rotation in Kingman County, in Kingman, Kansas, a town of about 2,500, where you couldn't possibly have the experience that a person would have in KU Health Systems in Kansas City. But that my point back to the bill and regulation in general, one of the big divergence between nursing and medical doctors has always been the term diagnosis. While the medical doctors always studied, learned, were trained in diagnosis, this bill, you know, there's language in it where the nurse practitioners turn completely away from diagnosis. They refute that they diagnose. But this bill suddenly scratches through that terminology and lays them out as skilled, qualified, ready to diagnose. Does anybody have any thoughts on that change in verbiage in the bill?
Very briefly, Rochelle Colombo again, Kansas Medical Society. That's correct. The language does amend what used to have a distinction between a nursing diagnosis and a differential diagnosis, which is medical training, to do exactly what Dr. White discussed, learning how to tell the one apart from the many, many thousands that look the same. So it is a distinct change. It is allowing for medical diagnosis to be initiated, which is the practice of medicine and surgery.
One quick last question and response, Senator Baumgardner.
Thank you, Mr. Chair. This question is for Dr. White. It has to do with, in the bill, it says that an advanced practice registered nurse may prescribe, procure, and administer prescription drugs and controlled substances on schedules 2 through 4. Could you address how that's different from who usually prescribes and procures drugs scheduled 2 through 4?
So I might need Rochelle for this too, but I know that currently for controlled substances, which I don't know which level that is, but for controlled substances, like I said, I've worked with 7 different nurse practitioners in my office. Anytime they needed to write a controlled substance like Adderall or an opioid, they would come to me and they would tell me what was going on with the patient and explain why they needed this prescription. And then I would actually write the prescription. So the biggest change, at least in my practice, would be, in a pediatric practice, would be controlled substances such as those. Rochelle, do you have more to say about that? Okay.
Thank you very much.
Committee members, we are out of time, past time, so we are adjourned. Just remember, get your questions to Donola as quickly as possible. Conferees, thank you very much. Everybody, have a great day.
Thank you.